And the assumption is that the BHMT SNP that she has is causing a DMG deficiency. The challenge with BHMT SNPs is that the data is largely inconclusive. If you look at her SNP analysis under the BHMT, I put in some more information about her particular SNPs that might be helpful for seeing why she is seeing some of the things that she's seeing physiologically. So if you go to, for this particular patient, her BHMT SNP didn't come up conclusive with anything, but if you look under her MTRR, for her particular genotype, and this is just for clinical reference, because this is from a pediatric. So notice if you start under MTR and MTRR, this is with reference to her homozygous MTRR SNP. In the studies that were referenced from PharmGKB, pediatric, all patients with the GG genotype may have increased likelihood of methotrexate-induced toxicity, oral mucositis, and increased catalytic activity of TYMS and leufoblast when treated with methotrexate. And so what that tells me is that there is something profoundly different with her MTRR. I've only seen the word all used with this SNP. I've never seen another SNP that uses the word all patients. The other thing that seemed relevant to me for this patient is female patients with the GG genotype and migraine who are treated with folic acid and vitamin B complex may have increased severity of pain as compared to patients with the AA or AG genotype. And so remember, that's folic acid and a vitamin B complex. I need to get the reference to find out exactly what the vitamin B complex was, but I'm assuming that folic acid was probably the major contributor to that increase in pain. The other one that stood out to me that I put into her report were her VDR. And so for her VDR, she was the AA genotype patients. And so I'm reading here, patients with the AA genotype may have a decreased risk of bone fracture when treated with calcium. If she were the GG genotype, she would have an increased risk of bone fractures when treated with calcium. And so I don't know exactly what the biochemistry is behind this, but what this tells me is that this genotype of VDR handles calcium differently than the AA genotype. The other thing that came up under her VDR, patients with the AA genotype and osteotitis deformis may have increased likelihood of resistance when treated with chlorinate bisphosphonate compared to patients with the GG genotype. So clearly there's something different about how this patient population handles calcium that's directly related to their VDR SNP. Okay, and those were the major things that stood out to me that I felt were worth putting into her report. And when I include things like that in the report, it's not to say that this is something that she is doomed to, and I don't always recommend some of the stuff that I will put in. I don't necessarily want the patient to see, because they can kind of take some of these things too far.